Hello, everybody. Welcome back for another conversation. Today, we're talking about everything renal, everything nephrology, and thrilled to be joined by our special guest today. It's Dr. Chiarra Ornillo. She was a fellow here once upon a time and now is an assistant professor of medicine at the Icahn School of Medicine and the director of our inpatient hemodialysis unit, and does so many other things. And I feel like nephrology is this amazing world of paradoxes that you're going to help us explore. So thanks for spending some time with us today.
Yeah, I'm happy to be here. Really
So great. So maybe you could start off just by telling us a little bit about like what a nephrologist does all day.
Yeah, so right now I'm on hospital service. So I am in the hospital day in and day out answering pages. Yeah, we juggle a very busy service. We have our hand in the critical care units. We are managing, critically ill patients that have acute kidney injury that need dialysis a lot. We also are doing consultations on the regular floors for, electrolyte abnormalities and acute kidney injury, AKI. And then we're also responsible for managing, chronic dialysis patients, both hemodialysis and peritoneal dialysis. And this is all while managing our outpatient population. So when I'm not on hospital service, that's where I am most of the time, the dialysis units. And I go to two. They are on all different shifts. They start from 5 in the morning. The last shift can start at 7. And I try to see them multiple times a month. It's a nice balance. I think, having that outpatient experience, both in the clinic and with your outpatient dialysis panel, versus, having the acute care experience and being in the ICUs all day. So it's really a nice kind of balance between the two, I think.
Yeah. I mean, it's amazing to me, and thank you for making time for us. It's like, because I've seen you live this schedule of hospital rounds with the residents, outpatients in our Union Square practice, 2 different dialysis centers, the inpatient dialysis center, and then calls all night around, everybody with a low sodium or a high potassium or whatever, they're coming to you for advice.
We get those 2 a.m. calls. Hey, I have a potassium of 8. There's EKG changes. I think the patient needs dialysis, and we come. So, it's a little bit of everything. Sometimes it's a little bit hectic, but I honestly find it very rewarding.
Yeah. And it seems to me like there's all this stuff that makes a lot of noise that we hear about, the people on dialysis, the people with these like acute changes. But then there's also this silent epidemic of chronic kidney disease. And I was just reading that there's something like 33 million people or something with chronic kidney disease. And they're anticipating that going up another 10% over the next few years. I mean, is this something new, or is this something, tell me more about that.
Yeah, so, I like to refer to it as the silent epidemic. It's actually a pandemic. Like worldwide, there's 850 million people suffer from kidney disease. And that is astronomical. And there's a lot of people that go underdiagnosed or undiagnosed. They don't have proper health care. So that number could be even bigger. Just to give you an idea, it's about, I want to say, double the number of people that suffer from diabetes. 20 times more patients than have HIV, AIDS, and cancer. So it's a huge problem, and it's just growing with our aging patient population with these chronic diseases like diabetes, obesity, hypertension. That number is just going to keep growing. It's just going to keep rising. So yeah, it's this silent epidemic because really patients present in the late stages. A lot of times they are not being followed up in, the primary care setting because they don't go to the doctor. I can't tell you how many people that we've had, I haven't been to the doctor in 10 years and I recently found out I have a creatinine of 3. That's a very, very common story that I get in the office. So it is silent because a lot of these patients don't have symptoms till they're in the later stages, which is unfortunate.
Right. I like what you said to me, I think the other day, about how the kidney is like this organ that we're not listening to, we're not percussing, all
No.
that stuff you learn in medical school about how to do a good physical exam doesn't really apply here.
Yeah, it doesn't. A lot of what we do is looking at numbers. A lot of what we do is like looking at the UA, examining what it's done over the last few years, proteinuria, those are the things that, we really hone in on. And, unfortunately, that's not always seen in the primary care clinics. And it's not, because it's a problem with the way that, care is administered. It's just, these patients are not being captured sometimes. And when they're not being captured, our preventative kind of measures, medications that help slow down the progression of CKD, they're not being used. So trying to capture these patients is really, really important. Trying to know who's going to progress to, end stage is really, really important.
Yeah, so it sounds like most people or many people with CKD with chronic kidney disease, don't even know that they have it, right?
Absolutely.
And so if I'm somebody watching this and I'm now all of a sudden I'm in a panic because I just told you might have this horrible illness that you didn't even know you had, what kind of advice do you have for people who want to know if they have chronic kidney disease, and for people who don't, or maybe even for people who have early stage chronic kidney disease, what do you tell them about preventing it from getting worse?
Oh yeah, it's about, living a healthy lifestyle. It's about eating right, staying away from really salty foods, making sure you don't develop hypertension, making sure you don't develop diabetes. Like diabetes is the #1 cause of CKD in the world. And that's followed by hypertension. So if you prevent yourself from developing those diseases, your likelihood of going into CKD is a lot less. So it's all about lifestyle, all about practicing good diet, exercising, maintaining a healthy weight.
Right. And some people just have a genetic predisposition for high blood pressure or for diabetes. So in that case, we got to make sure, as you said, that we're controlling their sugar, that we're checking for pre-diabetes, that we're checking for early signs of high blood pressure,
right,
and that we're keeping all those numbers under control, and that everybody's eating lots of fruits and vegetables, low salt, I think you said, getting some exercise, and trying to keep their organs healthy.
Yeah.
And then in order to get tested for CKD, I mean, from my perspective as a primary care doc, like we're checking their blood, depending on their age, once a year, once every couple of years, to make sure that their creatinine blood test for kidney function, is good and that it's not worse than it used to be. Does that sound like the right thing to be doing?
Yeah, no, absolutely. If they have, an increased risk, if they have diabetes, if they have hypertension, if there's a family history, doing a simple urinalysis, checking if they have proteinuria, and your standard, basic metabolic panels, all going to help us identify who is developing CKD, who needs to be referred to the nephrologist, who needs a biopsy. I mean, it's going to be captured in the primary care setting. Absolutely.
And then you started talking about people who have CKD, how we sort of know who's at higher risk and who's at lower risk. Obviously, we know we got to keep their sugar and their blood pressure and everything under control. There's some new stuff out there to help us make some of those decisions, right?
Yeah, I think there's some really great, programs and new algorithms out there. There's something called Renalytics, which is basically a test that we can run in the primary care setting and in the clinical setting for us as primary nephrologists. Basically uses, biomedical data from the chart, looks at your glomerular filtration rate, your creatinine, also looks at certain markers that are known to be associated with progression to CKD. And it's an algorithm. It's actually like artificial intelligence. By using all these parameters, we can actually identify who's low risk, intermediate risk, and high risk for progressing to, end-stage renal disease. It's probably the first of its kind. There's nothing that risk stratifies, someone's progression to CKD until the you know, advent of this. So it's really exciting stuff. And I think it's going to really help kind of hone in and help with the CKD epidemic here in the United States. It's really exciting stuff.
Yeah, so amazing. So for people who are low risk, I guess we can sort of reassure them.
Right.
And for people who are high risk, or, you know, when people have, you know, get diagnosed with stage 3 CKD to begin with, you know, the question I keep getting asked is like, do I have to make my first dialysis appointment today? Or, you know, how much do I need to panic? So how do we reassure them what kinds of treatments are out there for chronic kidney disease?
Right. So, you know, I think you mentioned before, making sure that, you know, blood pressure goals are being met. Making sure they're on the right therapies, you know, ACE inhibitors, ARBs, SGLT2 inhibitors are a really big player now. So, you know, if we are identifying these patients early and implementing what evidence-based medicine is saying works, you know, I think that should reassure the patients. You know, they don't necessarily have to come to the CKD clinic if they have you know, a creatinine that puts them in stage 3A CKD. They don't have to come every 3 or 4 months. I think as long as we're kind of maintaining their creatinine, we know that, you know, the urinalysis is not showing a lot of protein and they're on the right medications and they're meeting all their goals for A1C and their blood pressure. I think, you know, they could feel pretty confident that we're doing everything that we can. Like, honestly, we wouldn't do anything differently.
Got it. And so, all right, so then some number of these people, high risk or whatever, they progress to dialysis. And to me, this is like another key paradox in your nephrology world, right? They have a choice, or we have a choice between hemodialysis, where they go, you know, a dialysis center a couple of days, 3 days a week, spend a few hours there and get their sort of artificial kidney blood filtered, or they can do peritoneal dialysis, where they get hooked up at home usually and overnight or whatever, have that same sort of artificial kidney exchange. My sense is that most nephrologists would opt for peritoneal dialysis themselves, but almost every patient ends up on hemodialysis. Is there some mismatch there?
There definitely is, but it's improving. I will say
okay.
That it's improving.
That's good.
Yeah. So, you know, it's about educating these patients, having them learn about what their treatment options are. You know, that can only happen if they're already established, you know, patients in the nephrology office. And honestly, you know, unless they are in our care and we're preparing, because it involves a lot. It involves, you know, training. It involves having a proceduralist put in a catheter. It involves a lot. So, you know, the key is having us involved early and planning for this, planning as we see that their GFR or their glomerular filtration rates, creatinines are worsening, us having and opening that dialogue and letting them know, like, hey, these are your options. You can do this intermittent dialysis 3 times a week, or you can keep your autonomy, you can keep some independence, you can be in more control of your treatment and do something like hemodialysis or home hemo. So letting them know they have the options, educating them, I think is really a big key in, you know, the shift from the outpatient dialysis centers to home modalities. And I think we're starting to do that. You know, just 10 years ago, I would say it was about 33,000 patients doing home dialysis, and it's more than doubled. We're closer to 70,000 now.
But compared to millions, I'm guessing, patients on hemodialysis, right?
Yeah, I think right now, rough estimate in America, the US, it's about 750,000 people on like regular dialysis. So it is still a small portion, but I think, you know, with, you know, the reimbursements being better with Medicare, it's pushing us to kind of make that known to the patients. They can do dialysis at home.
Right. And some of this may all be driven by some sort of reimbursement. I mean, people may not know that, people with chronic kidney disease on dialysis are eligible for Medicare. That's a carve out from decades ago.
Right.
And that, I think, impacts probably some of why people choose this or that, or how some of the decisions get made, right?
Yeah, no, absolutely. And it's also about access. Not every freestanding dialysis unit in the community has a PD program. So, knowing where they're available, knowing where the big centers are, that's where you're going to have an opportunity to learn. And, even if you start hemodialysis, and that's how you started, if you started in the hospital, there's not a lot of places where you can do acute peritoneal dialysis. You can always switch in the future. That should be something that's offered to hemodialysis patients. Now, I know in my units, there's nurse educators that go around and say, we have home modalities. Do you think this is something that you would be interested in? And I have patients that switch. They'll try it out. Some of them like it. Some of them don't, and they come back to dialysis. So, it's really like an individualized treatment plan for each patient. Some patients really want to be in complete control of their care and they love PD. And then there's others that are frankly a little bit intimidated by it and they don't want to do it. So, trying to identify the ideal patient is also important. So, they have the best chance at succeeding.
Yeah. Are there other kinds of people who are not a good fit for peritoneal dialysis?
Yeah, so I think compliance is an issue. If you are not sure if your patient is going to follow the regimen, if you are a little bit weary of their ability to kind of do everything sterile, it kind of puts them at greater risk for infections. And of course, they have to have an ideal abdomen. Somebody who's had multiple surgeries or who has a huge hernia, they can't do PD. So we have to take all those things into account. Not every patient is an ideal candidate.
Right. And I sometimes think about all the room that it takes up for all the gear and whatever. Yeah. If you have a small apartment, especially in New York City,
yes,
sometimes you don't want to give up all this space to bottles and bottles of.
Yeah, it takes up a lot of space. And they look at the setup in the home and how close you are to the bathroom and if it's feasible. Like, it's a bit of a challenge with the space issue in New York City. So, they actually have nurses go into the home and just kind of see, can we do this here? What can we do in terms of deliveries and can we make this work? So everything is taken into account when we start someone on PD. So yeah, New York City, small apartments, it's a bit of a barrier.
One more challenge in New York City living.
Yeah.
So, it really does sound like you have an interesting job. You're dealing with all these like acid, base, and electrolyte abnormalities. You're dealing with people in the hospital, the sickest people in the hospital, in the ICU, the people in the emergency room, the folks in the office, people getting dialysis, home dialysis, or in the dialysis centers. And there's a silent epidemic going on, and there's millions every year, people newly diagnosed with chronic kidney disease. And yet the number of nephrologists getting trained is going down. I think I read in 2012, there were like 360 nephrology fellows. Last year, it was down to 291. And the trend has definitely been downward over the last couple of decades. And so why is it that you can't convince all your colleagues to go into nephrology?
Yeah, I think, to be honest, it probably can go as far back as medical school. Sorry, my lights go out. It can go far back as far back as medical school. I remember myself sitting in a classroom as a second-year medical student, physiology, looking at the nephron, seeing all these different channels, this and that, that's impermeable to water, this is not. The countercurrent multiplication system that's in place to absorb water, like that is really, really intimidating. And I think maybe at that level, trying to kind of fix the curriculum so that, it's not so intense, it's not so intimidating, it's a little bit easier to grasp. Because I really do think it really turns off a lot of medical students. Like, they probably look at it and they're like, I'm never going to need to know this. Like, I'm just, I'll know what I need to know for the test and that's it. But it's intimidating. And, it's an esoteric, it's a very cerebral specialty. You can't see the kidney, right? It's not like, GI, and it's not like cardiology. It's very much a cerebral subspecialty. So it's intimidating. So hopefully what we can do is, make the nephrology world more accessible. I think if they did electives, mandatory electives even, they could see what we do day in and day out. They can learn how we learn the material, how we'll explain it, and how it's really not that hard. I think that there's not enough exposure. I was fortunate enough to do a lot of electives during medical school on the transplant team with the nephrology team. Like, it's something that I come to learn and love because I was exposed to it. And, I made that choice. Had I not made that choice, I don't know if I would have been a nephrologist, but, I thought it was incredibly interesting. I thought it was, they were very well-rounded physicians and well-respected, and very, very, very knowledgeable. So, I am hoping that we can kind of get that point across again to our trainees. Last year, our program did pretty well. We sent 4 residents into nephrology. So, I'm hoping that, as we continue to mentor some of these residents, more interest will be there. But yeah, having an experience on the nephrology team, I think it really, really helps.
Maybe somebody will watch this today and decide that nephrology is their future.
I hope so. I hope so. We definitely need more. There's such a shortage right now across the board.
Got it. Well, thank you so much for joining us. I really appreciate it. And I know in your busy, busy day, to be able to take 25 minutes out for us is really special. So I appreciate it. Thank you. Thanks everybody for joining us.
Thanks so much.